HIV is not a death sentence, or it's not what it kind of was perceived, and I think some people still have that feeling from the 80s. HIV is a chronic, manageable disease, right? Your life expectancy essentially is the same. If you get diagnosed with HIV in your 20s, but you're in care and take your medicines, your life expectancy is expected to be 73, 74, depending on what state and other things like that.
Hi, welcome to The Vitals, Mount Sinai Health System's groundbreaking new video podcast. I'm your host, Leslie Schlachter, a neurosurgery physician assistant here at the Mount Sinai Hospital. Well, December 1st was World AIDS Day, and there's been a lot of updates over the last couple decades, and more recently with prevention, treatment, and management of HIV and AIDS. We're lucky enough to have Dr. Michelle Cespedes with us today, who's an infectious disease doctor and specializes in HIV, and we're going to talk everything HIV. So for those listening today in the audience, just for awareness, can you define HIV and AIDS for us?
So there's a difference. HIV is the actual virus. AIDS is the condition or the illness or the severe form of the illness. HIV stands for human immunodeficiency virus. AIDS stands for the condition where your immune system is essentially so low or so weak, you can actually be at risk of getting diseases from things that we commonly encounter, breathe in all the time, that a normal immune system would be strong enough to fight to prevent you from becoming ill. So AIDS is a severe form of the condition you can get from the HIV virus.
And so over the last 20 years or so, we see we see less people suffering from AIDS because we're managing HIV more appropriately, right?
Even better, more importantly, we are actually diagnosing people with HIV before they even have symptoms. So for the last 15 years, the recommendation for, just public health for everyone should have an HIV test starting from about age 13, 14, 15, essentially.
13?
As soon as you're old enough to go to the doctor.
Oh, wow.
Everyone should know their status. Right?
Okay.
So I think when some of us who are a little older in the 80s and 90s.
You went, some of us are a little older.
I mean, I know how old I am.
Together.
My skin is great. But we used to see people coming into the doctor, to the emergency room, already sick, thin, already probably have had the virus for several years, so it's taken its toll on your immune system. Now we recommend that everyone has an HIV test, and essentially if you're still at risk of getting HIV, get it again, maybe after you start dating someone new or for any other reason. Right. But everyone should know their status. And this way, you kind of know if you have HIV or not. Years maybe before you would present with symptoms of having a destroyed immune system. If someone twists their ankle and comes to the emergency room, we take your bloods, we kind of find out all this other stuff. You get an x-ray, but you're also offered an HIV test.
Just on a regular ER visit?
On a regular ER
that's
visit.
Outstanding. I didn't know that.
When at the other institution I worked at, we kind of rolled out a pilot when the recommendations to test everyone started. So then we realized we were getting such high rates of HIV positive tests, more than expected. And it turns out the doctors were kind of preferentially choosing who they thought this person looks like they might have HIV or all these other things. So they were kind of testing who they thought. So, you're going to get a higher response rate or positive test rate. But now if you test everyone and you make it part of routine care, right? Just like when you go to the doctor's office, we do your blood pressure and we do your weight, right?
We ask if you feel safe at home.
Right. Or are you sad? Screening questions, because that prevents heart disease. Or before you have a heart attack, we see if your blood pressure is high, we'll test your cholesterol. But all these routine things that we do are kind of prevention, kind of knowing where you are, taking care of it if you're in the risk factor or inching towards that.
That's a really great thing to know.
Testing, know your status before you're at risk, and if you're negative, how do we help you stay negative? And if you do have HIV, how do I get you on meds before your immune system puts you at risk of getting these bad infections?
I'm so glad our listeners are hearing that, because I could imagine somebody would come in, they're like, well, I'm just here for an ankle sprain. Why are you HIV? But it's just part of the protocol.
And just everywhere. And when you routinize it, they're not judging me. Do they think I'm dirty?
Yeah, they're not
do
profiling
they think I'm using drugs? Nope. Everyone I test.
That's awesome.
Right? So I was mentioning to you earlier that I lived in Chelsea for 20 years. one of the things I used to do is talk about misperceptions of risk, right? People think, oh, I don't do that, or I don't have this risk factor or use drugs. And I used to say, well, I'm a doctor, I'm educated, I do a lot of work in other countries, but one of the things I always do is get an HIV test about once a year. And they're like, why? You're married. And I said, well, part of it is if I'm going somewhere that might have a higher kind of prevalence of HIV in that country, I need to know my status before I go somewhere. But even just the fact that I live in this part of New York City that has high HIV rates, I'm actually probably more at risk of getting HIV just because of where I live, right? Not because of drug use or other risk factors than, let's say, someone who's from a different part of the country that has very little HIV, right? Someone who's using IV drugs in a part of, Utah or Colorado, Wyoming. There's very few humans in Wyoming, right? But that helps dispel what misperceptions of risk, right? Your zip code can be a bigger factor for your risk of getting HIV more than some of the other things. So I think that takes the onus
takes some of the pressure off.
Yeah, right?
Yeah.
This is just health. This is health.
Can you walk us through the incidence, prevalence, and then we'll talk about treatment of HIV over the years? Because, I'm 46 years old. Okay. I mean, I remember when Magic Johnson had, everyone of our age remembers when he was like, everyone got scared. And it's totally different now. So can you kind of walk us through the history of the incidence and prevalence?
So incidence and prevalence really makes a difference, kind of. Incidence means kind of how many new people are diagnosed or have the disease. Prevalence, or how many people actually have it and are alive with it. Right. Prevalence is actually a little bit more because we're testing more people and picking them up while they're alive.
And keeping them
alive
longer.
And we're keeping them alive longer. That's the trick. I want prevalence to go down. I want incidence to be zero. I'd rather no one have newly diagnosed HIV. But over time, the biggest advances are really kind of routinizing, making sure people get tested, know their status, and do it routinely if they're at ongoing risk. And the biggest kind of new kid on the block over the past 13, 14 years or so is the ability to prevent HIV if you're in a group or you're at ongoing risk. We've actually found, instead of taking at least two medicines or two different classes of HIV medicines for treatment, if you actually have medicine inside your system already before you have that either risky sex act or...
That's called PrEP, right?
That's called PrEP.
Right.
Pre-exposure prophylaxis. We can actually prevent HIV more than like 97% for people who are in the highest risk factors. For the first decade or so, it was a tablet that you can take every day. Our French scientist counterparts, they said, look, what if I'm not at risk every day, or if I know I'm just going here for this month or for vacation once it's here. There's an option called on-demand PrEP. You can take it within a day or so before the risky sex act, if you know when that's timed going to be, and then for a day or two after. So that's called on-demand PrEP. But actually, in the last 3 years, we've actually had the ability to actually give what's called long-acting injectables. So instead of having to take a pill every day, there are two options. There's one option to get an injection once every 2 months for HIV prevention. And just this summer, just a few months ago, there's actually another option that not an injection in the muscle, but under the skin, subcutaneous, that lasts every 6 months.
Wow.
So that's incredible. I'm like, that's pretty great.
Is that something that you get that in a doctor's office?
You can get it in a doctor's office. You can get it in a doctor's office. Because that's newly FDA approved, some of the clinics that are familiar with pre-exposure prophylaxis and maybe even this other injectable that's been around for a year and a half or so probably have faster access to it.
Right.
But the fact that it's available and FDA approved and options, right?
Did a lot of people come knocking for that one when it came out?
People knew about it. I think now we're making sure that their insurance covers it. It's a new kid on the block.
Yeah, so
but
we have to wait a little bit.
Scientists, we have been waiting for it. Sinai, we enrolled people in the study that compared it to the standard tablet, once-a-day tablet option for pre-exposure.
What's your preference for patients, or is it like patient-dependent, lifestyle-dependent?
It's patient-dependent. What works best for you, right? Because pre-exposure prophylaxis means that you're likely still at ongoing risk for acquiring HIV. You know, it only prevents HIV, but there are other STDs, right?
Right.
So people come in for testing for syphilis, for chlamydia, for gonorrhea. We make sure the medicines are, you know, agreeing with their body, not giving them any side effects. Every opportunity to see them, talk about risk or ongoing risk, right?
Right.
You know, I'm with a dedicated partner now. We're not seeing other people. We both know our status. I don't necessarily think I need it longer. So still points of contact. So we still see people every 2 to 3 months for the other STD testing. But some people prefer tablets. Some people say, I already have tablets.
Right.
Some people are scared of needles. Just options.
Of the patients that are good candidates for PrEP, doesn't matter the type.
Okay.
How many of them do you think are actually getting it? What percentage are actually participating appropriately?
So part of it around the country, we're at an advantage in New York City. Sometimes, you know, the states or what they will cover or our insurances. New York has been very proactive for the whole past decade, making sure people have access to PrEP if they want it and meet criteria, regardless of their kind of ability to pay. Or we think it's important enough to prevent HIV that New York State has actually dedicated funds and resources and partnered with some of the pharmaceutical companies to get discounted rates or help people who need it get it. It's not that easy around the country, right? And insurance differences and whether some states have opted in or out of kind of Medicaid or expansion states, so it makes a difference. So one of the organizations that I sit on the board of the HIV Medicine Association, and also I'm on the board of directors for the Infectious Disease Society of America. One of the things that we advocate for, especially in this changing climate of competing priorities, I think, in terms of health or what constitutes health and science and information and kind of research-based information. One of the things that we advocate for is education and access, right?
Right.
Making sure our colleagues on Capitol Hill who sit on some of these committees that decide where funding goes, or making sure they know the burden of HIV and all the advances that we have come or obtained over the years,
right,
and making sure they prioritize equal access to that, or PrEP for all, and access to treatment. The other thing that's interesting is that I think I take it for granted. I'm in New York. I have colleagues competing in different competing institutions, 2 blocks here or a mile or 2 here. We take it for granted that most counties across the United States don't even have an ID physician or a doctor who's well-trained or really familiar with this.
I didn't even realize that was a thing. We definitely take that for granted.
I didn't realize that. So it turns out about 80% of counties don't even have one ID physician. Wow. So one of the things that we try to network in...
Just for those listening, ID is infectious disease.
Infectious disease.
Yeah.
You know, if you want to stay healthy and stuff like that, things that you don't want to catch in the airport or your kids to bring home, people usually call or get to us some way or another. One of the things we try to do is make sure that we're accessible or able to network either through telemedicine, teaching, advocacy, all these other things for people who might not necessarily see as many people living with or at risk of HIV as well, but making sure that they have access to the resources, the guidelines, and things that have been a little bit harder to access over the last few months with some of the change in administration or how they disseminate information.
Yeah, no, I can imagine.
Yeah.
So there's the prevention, which it sounds like PrEP has done a really good job. And then there's like the initial treatment, and then hopefully kind of maintenance long term.
Correct.
So when somebody does present with new onset HIV, and I'm not talking about the people where it's kind of they came to the ER for the ankle sprain and it was picked up. If someone is actually newly diagnosed and they're ill, what does that look like to become sick with HIV?
So it's different. It's different for different people. So the things that we're seeing now, hopefully if someone's in care or has access to a doctor and everything else going well, if they're newly diagnosed on the outpatient side, we kind of make sure that their kidneys are okay. We're making sure there's no other infections. There are a couple of infections, actually, that we're very mindful of, things that travel or that you can acquire the same way that you can acquire HIV. So we mentioned sexually transmitted diseases, but especially hepatitis B and hepatitis C, kind of the same, either social things and also sexually transmitted. But it turns out HIV medicines, some of the HIV medicines also treat hepatitis B. So one of the things we're very mindful of is finding out someone's hepatitis B status.
So there's probably like a new diagnosis order set.
There's a new diagnosis order set. We want to make sure that you're healthy otherwise. We're going to check for the other STDs. We're going to check what's called a hepatitis panel.
Okay.
Hepatitis A, B, and C. Hepatitis A isn't sexually transmitted, but, food-borne and when you travel.
Right.
But there's a vaccine for it, right? So let me find out if you need a vaccine. I'll get one to you.
Okay.
Hepatitis B, sexually transmitted. You can also get it through IV drug use or be born with it if your mom has it. But because some of our HIV medicines can also suppress or treat hepatitis B, I really want to know if you have that. That'll make me choose different medicines.
Right.
But I can also vaccinate you against that as well, right? So if you... the vaccine wasn't available when we were kids, but most of us, especially if we work in a hospital or maybe going through college, I think I got mine in med school, you can get a vaccine then as an adult. But for the most part, we try to vaccinate children, so you'll never get it, right? Just in case your mom had it or got exposed during pregnancy, vaccinate you now. But there are some people who just didn't get a vaccine as a kid, right? And then the third of the hepatitis panel, we also do hepatitis C. Again, not a vaccine for it, but one of the only hepatitis virus that we can actually cure. HIV and hepatitis B we suppress with medicine, so you need to be on medicines for a long time for now. We're working on cure. But hepatitis C has a different kind of life cycle, and we can actually cure hepatitis C. So finding out whether someone has hepatitis C at the same time they have HIV, we get them on treatment and cure it in a couple of months.
What
so
else
that's
is on that list?
Of other STDs or other
STDs, and then do you get like
labs
chest
to do
X-rays?
that?
What is kind of like your
So
base
we don't
test?
necessarily go and get chest X-rays for everyone, but it depends on if they're in that AIDS, kind of like that bottom of the barrier, really susceptible to a lot of infections they might not even feel yet. We kind of do a little bit more work. If they have a normal immune system, like the HIV hasn't been around long enough to knock down their immune system, again, we do like the basic labs. Are your kidneys okay? Is your liver okay? Getting the hepatitis labs. The other things that we get is what's called the CD4 count. That's the one that measures the strength of the immune system, right? Normal
so
if you're not sick.
the viral load for the HIV virus.
The HIV viral load, I try to tell patients, are kind of like the number of copies of virus in your blood. When I give you medicine, I want the medicine to get that to undetectable or, so you still have the virus, but the medicine is putting pressure on it.
And then we want the CD4 count.
The CD4 count is your soldiers, your immune system. So I want that in the normal range, right? And CD4s are supposed to fluctuate. Like you and I, even if we don't have HIV, like if I get a vaccine or if I get a splinter and get a little infection, my CD4 count goes down. It goes and fights that infection. It leaves my bloodstream, fights that infection, and then naturally goes up. I might not even feel that. But you want to have a certain number of soldiers that can take care of little things so you don't even get sick or feel that. But when it's too low, that's when people have AIDS or get infections from things that they shouldn't.
So if the CD4 count is low because it's busy fighting the HIV virus, it can't send those soldiers to fight these other things.
It's got competing priorities, remember?
So that's why you're more
you're more susceptible to other things. Right?
Okay.
Because we have things in our body. We get inundated, we eat parasites. We don't see dirt at the bottom. We breathe in dirt. I'm sure you do. I saw you. I saw that dusty cup that you drink. No, all jokes aside, but you really don't realize how well your body is protecting you, right? The whole time. Your skin's protecting you from all this other stuff, right?
What about when I was looking into you, getting ready for today, I learned that one of your focuses is HPV.
Correct.
Human papillomavirus. So how does that relate to HIV or coincide like you were talking about with hepatitis?
So similarly, there's some of these viruses that are essentially ubiquitous. We've come across this stuff. We've been kissed or we've shook hands with something. We've gotten sick before. I'm not sure if you're old enough. I actually had chickenpox as a kid.
Oh, yeah, I did.
There's a chickenpox vaccine, so our kids probably don't get chickenpox.
They'll never know
they
what
don't
we
know
went through.
Fun. I still have some scars and such there, right? But there's some viruses that essentially live inside your body that your immune system keep in prison or keep in jail, all right? And there are other viruses that your body sees, but over time we'll get rid of it, right? HPV is one of those viruses that most of us have been exposed to over time, especially once we start having sex, but our body can usually get rid of it in a year or so. Women with HIV actually tend to that virus tends to stay around longer and cause more problems. So when we go for our GYN and get a pap smear,
this is us getting pap smears.
I don't know if this is if you know, you know, right? What's that? What the young people say? If you know, you know, right? So when you get a pap smear is looking for evidence of abnormal cells caused by HPV, the virus, right?
Right.
For the most part, if you get some virus there, your body can take care of it. If it's there too long, you start to have some damage or some abnormal cells that your
that can
pap
put you at
smear.
risk for cancer.
Yeah, that's right. HPV, there are many, many different types of HPV. Two types, the main two types can cause either warts, not sexy, make you sick, no, but nobody wants warts if they can avoid it, right?
Preferably.
And there are several types that actually are precancerous or more likely to cause cancer. Now, so for the past about 18 years or so, there's actually an HPV vaccine.
The Gardasil vaccine.
Gardasil vaccine. Yeah. When it came out, it only helped your body make antibodies to about 4 types. 2 of them that cause warts and another 2 that were the biggest ones that caused cervical cancer and even anal cancer and penile cancer. So that was called Gardasil 4 time. Now we have Gardasil 9, so still covering the 2 for warts, but then now the top 7 that are actually kind of the most common that cause cervical cancer and the precancerous ones.
So for people who have, like, I have teenagers.
Yes.
My daughter's 17, my son is 19, and they had Gardasil years ago. Are they supposed to be getting the updated dose?
No, that's fine.
Oh.
That's fine.
What if they had 5? I want them to have 9.
That's okay. They've done enough, right?
They've done it. Okay.
You know, going to routine care. And then the biggest thing, so it's not even just a benefit to them. The biggest thing that's more important is what's called the term herd immunity. The more people in the society who actually just even get the vaccine, your kids are
17, 19.
So they only got theirs about 6-7 years ago. I think it was already up to the 9-valent or one already with that.
Okay.
But more importantly, it's more important for everybody or as many people as possible to get vaccinated so that there's just less HPV floating around no matter what. And then it'll cause more protection on a community scale.
Okay.
But
so what happens with HIV patients with HPV? They're more likely to have...
So they're more likely to have the HPV stick around in their body longer. So we're more mindful of screening now. Okay. And then the other thing, it's really, we were born at the right time, but our kids were born at the right time. Even more importantly than just the scraping and looking under the microscope, we can actually do DNA and kind of like looking quickly for some of these high-risk types. So it can determine, you've got some HPV there, not the ones most likely. Maybe we just give you another pap smear instead of waiting 3 years, maybe 6 months or a year, instead of waiting this one. So it can really help you determine next steps or how frequently or how often you should be screening.
I feel really lucky that I work in healthcare. I'm fully aware of the benefits that I have of being someone who knows how to use healthcare to the benefit of myself and my loved ones. How do you handle the populations of people that just don't have the healthcare knowledge to advocate for themselves, to get all this preventative health, but also to screen and treat appropriately in the right populations? So how do you manage that in your work?
So one of the things I'm very mindful of is when people talk either about health literacy or access, and I say, is it an access or literacy, or is it messenger or how we're speaking about it, right?
Okay.
So I think being mindful of how we message and maybe who the message is coming from, right? Should it be maybe a younger person for college kids? Should it be me for, older black ladies in New York City or postmenopausal ladies or things like that? So I think working on misperceptions of risk, not just from the patient side, but as I mentioned before, even from the health provider side.
Right.
I've seen older people in their 60s and 70s newly diagnosed with HIV who have primary care doctors who doctors never spoke to them about sex or risk or just assumed that they're okay.
Yeah.
I'll never forget
it. I'm guilty.
I've never forget when I worked at another institution in the city, a woman in her 70s, 72, I remember her clearly, 72 years old, was being followed by the primary care clinic, had asthma, would get a pneumonia once in a while, but just had a pneumonia that was really just acting just not right, or she was very sick, she had to get hospitalized. And it turns out that she had what's called PCP pneumonia or pneumocystis, carinii, or
Didn't that used to be like
Dvorkia.
Girovecchi,
Yeah,
like when I was in
Dvorkia,
PA
it's a new
school or
name,
something,
but
yeah.
we have the letters for it. But PCP pneumonia, and they called an infectious disease council. What's happened? Why does she have this? This is, this is. So we go and we talk to her. ID doctors. We think of HIV. We did a few other times. Turns out she was in fact infected with HIV, even though
she did not know.
She did not know. She had a primary care doctor she was seeing a couple times a year. Already had asthma and stuff like that. And she goes, actually, my husband had it or died of it or something like that. No one ever asked me. I thought maybe you guys are testing me or something like that too. But just thought I didn't have it.
Unfortunate.
Yeah, just thought I didn't have it. But just no one thought about it. Or I think people are not necessarily comfortable talking about some of the risk factors with HIV. So sexual health, taking a deep sexual history, drug use history. Even I can say I was guilty of it when I was dating. Did you really ask somebody you were dating, have you ever used IV drugs? Right?
Yeah.
Did you get an HIV test before you and I become intimate? Not easy stuff.
No, not easy.
But it wasn't easy then. It's not easy now. But once I'm comfortable talking to everyone about that, I ask everyone. I usually start off, if I'm meeting a new patient, saying, I'm going to ask you some personal questions. And they say, how much do you smoke? And that kind of like, oh, that's not that personal. Right?
Yeah.
Or how much
You're like,
alcohol do you have? Like
started.
that. Just getting started, right? But they realize I'm kind of asking everyone the same questions. Do you have sex with men, women, or both? Right? What are your preferred pronouns? Right? Is there anything else that you do? Right? Even women who only have sex with women, so we talk about risk factors, what your other partner is doing, shared toys, open relationships, and they're like, oh, this is something that you do every day. It's not that you're making a judgment about me. I was like, no.
Yeah.
I could probably add more years to your life if I get you to stop smoking,
right?
Or eating fast food and just going things like that too. But HIV is just a part of the care, and I do this for everyone. It's not about you. It's about health.
I'm sure that story comes up all the time about this 72-year-old woman.
I'll never forget it.
Right?
And I do mention it.
But you don't need to go through a divorce or move into an assisted facility. This could happen anytime. You could be in
anywhere.
A committed marriage and you never know.
Right.
So it is something that you can't just be done with once you get married. You have to continue doing it because you just never know.
So I think having open conversations and feeling kind of trusting your medical provider enough to be open like that.
Right.
I always find it interesting when we have patients in clinic who come to us just for their HIV care, their HIV prevention, but have another doctor somewhere else. They're like, that doctor doesn't know about what I do or other stuff, or they're not as good with it, or they've never asked me. I said, oh, okay.
You know what I just thought of? You were saying that when somebody comes into the ER, it's just part of the questions
routine,
to ask.
It's
What if LabCorp, Quest, BioReference, all these labs? I send my patients for labs all the time. What if you were able to say, when you're sitting in the room, there was a sign that said, would you like an add-on HIV? Can they do that? Or it has to be ordered by a provider, though.
That has to be ordered by a provider, but we've actually made it easier. I don't know if you remember when you were in training, there used to be all this counseling and, HIV. I was like,
you have to sign a paper.
You have to sign this paper. Now we've made it easier. It's part of healthcare. Do you agree or do you say yes? You can't just HIV test someone without their knowledge, but it doesn't have to be kind of like this, make sure they're not going to jump out of a window, or are they going to attack me, or what is it? No, bring it down, right? Yeah. HIV is not a death sentence, or it's not what it kind of was perceived, and I think some people still have that feeling from the 80s. HIV is a chronic, manageable disease, right? Your life expectancy essentially is the same. If you get diagnosed with HIV in your 20s, but you're in care and take your medicines, your life expectancy is expected to be 73, 74, depending on what state and other things like that. So I was serious when I kind of jokingly said, I can add more years to your life, not just by knowing your HIV status. If I get you to stop smoking,
that's the problem.
Or convincing my patients to get your colonoscopy. It's not your HIV that's going to take you out. It's you not following through with your colonoscopy or other things that I can help prevent.
Yeah, I would imagine that's changed over the years. 40, 50 years ago, people were dying of AIDS. Now people are dying with it, not from it.
Correct. So Sinai is one of the few places remaining, even in the city, but even around the country, that still has a dedicated inpatient HIV service. We don't call it that for lay people on the inside. But essentially a medicine service that's dedicated to taking care of the people living with HIV who would kind of also benefit from an HIV doctor's knowledge. Like,
Right.
if you're here for your heart attack or your knee replacement and you have HIV, you don't necessarily need that specialty service. But people ask, or when residents are interviewing or they want to come here or join the program, they're like, why? Or what's different about Sinai? Or why are Sinai's patients so sick? I'm like, no. It's why are Sinai's patients doing so well and living so long, right? An interesting thing about Sinai is that as an institution, we are the institution that has the largest number of people living with HIV who have received organ transplants, right?
Yep.
So think about that,
that used
right?
to be a contraindication.
It used to be a contraindication. We were one of the few sites around the country who were part of the studies that actually allowed people living with HIV to accept transplants from other people, living with HIV. Now we've actually even expanded that. But people are living so long and so well that their immunosuppression, or the medicines we give them to keep their immune system down, is because we don't want them to reject the DNA from somebody else's kidney, right? Their transplant. But they still kind of need the expertise of someone who deals with infections in people.
Is that like are there dosage adjustments for that because of all of the?
They need different immunosuppressives, but if they have a normal CD4 count number, so like a normal immune system, they get kind of normal dosages of the immunosuppressive medicine so they don't reject the transplanted organ. But if they're coming into the hospital, let's say that they have a pneumonia or a urinary tract infection, your immune system is a good thing to help you get rid of infections and stuff like that. So we will adjust their transplant immunosuppressives maybe for a week or so they can help get rid of this infection, but probably not long enough that they're going to put their transplant at risk and then bring it up and stuff like that too.
What about for patients, because now patients are living longer and better with HIV and they're not getting into the AIDS category. Those patients are going to get cancer. They're going to have so what happens with HIV patients who need to go on chemo or immunotherapies?
They get their chemo. We adjust or choose HIV medicines that won't interact with their chemo often. But there's some infections that can lead to cancer. Remember we talk about HPV, right? So HPV, I think most people think of it as cervical cancer, right, or cervical cancer only. It's associated also with anal cancer.
Right.
So there were other infectious etiologies that lead to cancers that we used to see more in people with HIV in the 80s or 90s before we had good medicines, before we tested people early.
When I was in urology for 10 years, we saw a lot of the patients with penile cancer with secondary to HPV.
Stuff like that. So HPV, right? But, I think even for all of women or most of America, we were getting pap smears. We were always taking care of the cervix. What people weren't getting routinely? Anal pap smears, right?
Well, now they do now. When they see an ID doctor, right?
For HIV patients, if you're in these categories. So what we've seen is all of the other cancers that were associated with AIDS in the 80s and 90s, almost down to zero.
Yep.
Except anal cancer, right? So people used to ask, why didn't we see this in the 80s and 90s? I said, you know what? People were dying of PCP pneumonia in 2 weeks, right?
Before they couldn't live long enough to get that.
They didn't live long enough to even have the luxury of getting cancer diagnoses or things like that, too. So now we're kind of learning from what we've done with cervical cancer, proper screening, getting the right people, treating it, keeping people's immune system high long enough that we're more mindful, and we do a lot more HPV anal cancer screening for both women and men. And again, not just men who have sex with men, or even if you've never had anal receptive intercourse, you might still be at risk.
So that's a perfect transition. Sure. I wanted to ask you, you kept saying risky behavior or
Correct.
at-risk population. Can you rank risky behavior?
Okay. So sometimes, again, remember, similar like I said, sometimes your zip code is it's kind of who you're having sex with, depending on if there's a high prevalence of HIV in a particular group.
Okay.
So in terms of, there's risky sex acts, right? And of course, IV drug use, if you're using needles that somebody else is using, unclean needles, we've seen that. But again, sometimes it's really more about the population that you're having sex with. So in terms of, I think, highest risks, in terms of acts or things that you can do, sharing needles for IV drugs, no bueno, right?
Okay.
So what's interesting over the last decade or so, I think we kind of think of HIV hotspots is the hotspots in the 80s and 90s. Miami, San Francisco, New York.
Major cities.
Major cities, places that are known LGBTQ friendly or hotspots, or where people find community, or and where some of these communities might be more marginalized, or have sex in exchange for shelter or money or food and things like that. But also other risky behaviors.
So
right?
like blood on needle getting
Blood
put
on
into.
Needles. But what we're seeing is HIV pop-up outbreaks in interesting places. About 10 years ago, a small section of Indiana had an HIV outbreak. West Virginia, and they're like, what's going on? Those aren't, big LGBTQ havens. And this is literally sequelae of the opioid crisis.
Yeah.
So essentially, pain medicines, or people are taking pills and tablets.
Escalated.
When money runs out, heroin or IV heroin use is often kind of like the next step in that paradigm or in that continuum. And places that maybe didn't have ID docs or weren't used to seeing hepatitis B or, infections that you get with needles and needle exchanges, maybe didn't have, New York City, we've been offering people clean needles, as part of harm reduction.
Like if you're going to do it, here's clean needles.
Not ideal, right? But I didn't know in some parts of the country, it's actually, if they find clean needles on you, it's actually an offense that you can get arrested for.
Oh, yeah, I didn't know that either.
Another friend of mine who works in the Midwest, he goes, Michelle, you take it for granted that you guys are in New York City, you guys have trains or commutes, stuff like that. He goes, if you're using drugs or really desperate for money, what would you do for money? I'm like, I don't know. He's like, I don't know, rob or steal or something, I get, right? He goes, well, if you have something that you could sell, what would it be? I was like, what are you talking about? He goes, most people, the thing that they could sell to get money quickly is your car. I was like, oh, New York, most of us don't have cars.
Yeah, no, that's.
And they're like, no, you get. He goes, but what happens when you sell your car? He goes, you can't get too far. You get around your friends in a bike, right? So now all of a sudden you're kind of using and exchanging drugs and having sex with people right in your community who are also maybe caught up in the opioid crisis, and then you'll see outbreak. All it takes is one person coming in with hepatitis C or HIV, and that whole community. It was really fascinating to get all the details about that Indiana outbreak about 10 years ago.
So IV drug abuse,
IV
number
drug
one.
use, risky, unprotected sex, especially if you don't know your partner's HIV status, or from certain populations where HIV is particularly high. In New York and in the States.
But with risky, unprotected sex, does it matter what the viral load is in that person?
Of course.
Okay.
Of course. So if the person who has the HIV, if one person is positive and one person is negative, the person who has HIV is actually on medicines and undetectable, actually probably unlikely to transmit no matter what, if they're the receptive
Especially
partner.
if that other person's on PrEP.
Correct, right? So there's a campaign we did a couple of years ago. It's still around, but you'll see the term U equals U. Undetectable, if you're HIV, living with HIV and undetectable, U equals untransmittable.
Okay.
So that's for sex. We don't really have the data for like breastfeeding and things like that, but really that was the campaign. If one of the partners has HIV, the most important thing the partner living with HIV can do to protect their partner is to stay on their medicines and be undetectable.
Okay.
On top of that, if you want to be extra careful, the person who doesn't have HIV can actually take PrEP for even extra protection. Sometimes we have what's called discordant couples who are married and want to have a baby, making sure that the partner without HIV is on PrEP, even if the other one's undetectable or there might be things like that, right? Being extra safe.
What about the difference between male-male partner, female-male, female-female?
So sometimes it's kind of anatomy. The person who is at higher risk is always the receptive partner, just because of like friction and tears and things that you don't see, right? Many even men who have sex with men, sometimes both partners can be the receptive partner, but it can depend on, presence of tears, presence of other STDs. That's why it's important not to have any open lesions, not to have any syphilis, anything else that brings inflammation or infection anywhere near or around there makes it easier to get HIV, even if you don't see any breaks in skin or things like that, too.
What about oral sex?
So oral sex is a risk, but definitely not as much of a risk as vaginal or anal sex, right?
Because of like friction and tearing.
Against friction, but this is a different orifice, different musculature, and again, open lesions or presence of blood or tears, right? If you have poor teeth or bad teeth or things and stuff like that, gingivitis, anything else that can make it, but definitely a lot lower. I wouldn't say nil, nothing's ever zero,
right?
But a much lower risk or very few reported cases from oral sex alone.
What other IV drug abuse?
IV drug abuse,
sex acts,
right?
What
Being
else?
born to a positive mom.
Okay.
So one of the things that we do all over the country is every pregnant woman, if she's in care during her pregnancy, gets tested for HIV at least once, and preferably at least once, and then maybe right in the third trimester, just in case if there's risk or ongoing risk, or if we're not sure about the partner's status or anything of the sort. I don't see it often, but every once in a while we'll come into contact with a mom who declines testing. It's called opt-out testing. Right. So we offer this test to everybody, but we let moms know, even if you say no, all babies who are born are tested for a couple of diseases, making sure their nutrition is right, they can handle things. But HIV is one of those as well. So we'll know the status because all babies are born with their mom's antibodies, right?
I would imagine a mom would want to know.
I think so.
What if a mom, let's say a mom is diagnosed at the time she's pregnant.
Okay.
Is it possible, even if that mom has a high viral load, low CD4 count, that the baby, with the mom getting treatment and then getting treated at the time of delivery, that they could not be born with HIV?
Most babies are not born with HIV.
Okay.
So even before treatment was available, the rate of transmission of a pregnant mom living with HIV to the baby, all things being, is about 11 to 15%.
Okay.
Not zero, but not great. If we get the mom treated and now we get her undetectable, or at least a viral load below 1,000, that's low to us, right? The baby is not likely to be born with HIV. We give all babies born to moms with HIV some medicines anyway, just in case.
Yep.
And the real risk of transmission from mom to baby is really at the time the baby's being born, when the placenta is ripping away from the uterus and there's all that mixing of blood. There isn't that much mixing of blood before the babies are born.
Right.
But we can really get that down to essentially less than a fraction of a percent if we get the mom on treatment and undetectable before the baby's born.
And what about healthcare workers? So as someone who works in healthcare, I'm a surgical PA.
Correct.
I had a needle stick many years ago. And you go to the ER, you go to employee health, you have to ask the patient permission to screen them, and then they ask you if you want to go. How's the incidence of that been going? I mean,
fantastic.
Okay.
So that, remember we spoke earlier about PrEP, pre-exposure prophylaxis?
Yeah.
If you get stuck by a needle and it's a high risk, right? What kind of needle, or where did you get stuck? Did
exactly
you see
where?
blood?
Are you sure it went through?
That's okay, right? Were you wearing gloves? Like that too. That's called post-exposure prophylaxis, right? And it can depend on if there's a needle that had blood, or were you in the patient, were you sucking out blood from the patient, doing all this stuff. But usually most people say, you know what, this is too much for me. Just give me the medicines or I'll figure it out, right? So again, if we know that the patient you got stuck from, whether they have HIV or not, we test them, find out in 15 minutes. If they do have HIV, are you undetectable or are you not? What medicines are you talking about? Even if you're undetectable, like you're undetectable when you took that test last week, or you're undetectable now. So it's all these things that go into your head. But the most important thing, if the person who gets stuck, opts on or is recommended to start post-exposure prophylaxis, is getting that medicine in your mouth immediately.
Like what's immediately?
So within the first 2 hours is best.
Right.
Within the first 36 hours, not great, but better than nothing.
Yeah.
And once you hit kind of after 36 hours, after 72 hours, it's too late, right? Post-exposure is not just for needle sticks, but also kind of sexual assaults or anything of this sort like that. Not everybody comes in within 2 hours if they can, or
in
other
healthcare,
things and stuff
I
like
have
that
people
too, right?
that have had needle sticks and they're like, I'm really busy right now, I have discharges, I'll go at the end of my shift. And I'm like, no,
please,
you go now.
Go now, it's better, right? Or we can
so within 2 hours is
within
preferred.
2 hours is ideal, right?
Okay.
If occupational health is open, you can go right there, but the ER is always open.
Yep.
Right? They always have access to one of the
and
ID
they take care of employees really
They
quick.
take immediately.
Yeah.
We have all the medicines that you need. We can get you in the clinic. We want to know your HIV status right there, and just in case you had HIV for 3 years and you didn't even know it yet before this
and we
needle
don't want to
stick.
blame it on that.
Right, and we just don't want to start the wrong medicine. We want to get you all the other tests and all the other things that we want to do, right? But we want to make sure that you're HIV negative now, that you're okay. For women of childbearing potential, we want to know if you're pregnant or not. The medicines are really quite safe. We actually use those same medicines in pregnancy, but we want to have everyone as informed as possible. We test all women for their pregnancy status at the time we start meds, no matter what. But those are some of the things we would do. But it's important. And I've seen sometimes people in training, surgeons in training, or they didn't want the other surgeon to know that they stuck themselves at the table and just don't want to make a big deal out of it. Sometimes peds in the NICU, those little fat legs can kick, right? You're trying to get stuff. So sometimes it's, not necessarily poor technique. It's just...
it happens. It
happens.
Like
our
we're
job,
human.
Right?
Right.
So again, demystifying it. It's not shame. Like, you're doing everything right. I've had some people, they're like, oh, some urine splashed on my arm I want. And I'm like, no, right?
Yeah.
That's not appropriate. We try to talk them down and really educate. I try to use the radio voice and talk them down and, taking medicines for a month.
Was the urine bright red?
All right, did it get in your eye? Can you taste it, right? It got on your shoe, and we're okay, right?
Yeah,
watch
we're
your
okay.
shoe. But I think that's some of the trauma or the PTSD about, HIV or 90s, or I'm going to die, or no one will love me, and I can't have kids. You can have kids.
It's
you can
totally different now.
Totally different now, but we're working on doing a better job of getting the information out, right? People, you can have a baby, you can have a family, you're not necessarily infecting your partner, you're not doing all this other stuff, and you can have a full life. There's celebrities, right, who some more open than not.
Yeah.
I did an interview with Charlie Sheen when he originally announced or disclosed that he was living with HIV. And we talked a little bit about kind of protecting his partner and the importance of staying on medicines and being undetectable and things like that too. So even people with access can get it wrong sometimes too, right? Yeah. But I think there's something to be said that I have this, I'm living, I'm doing well. We mentioned Magic Johnson earlier, right? So I had a patient.
Still, I think, is like the poster
He's
boy.
fantastic and happy and philanthropy and traveling on his yacht to Croatia and eating all this great food. So I think that's a good way to see about it too.
As an expert in your field, and obviously you see patients and research, how do you make sure that the next generation of ID doctors who specialize in HIV get the appropriate training and keep this moving in the right direction?
I think that's a fantastic question. To some extent, HIV isn't necessarily one of the sexiest specialties, or ID in general, all of it. But I think kind of making sure they know what a career in ID and what HIV looks like now. I think, I'm on service with the medicine residents now. So we're seeing sicker patients in the hospital, or people not doing well, or our transplant patients. And I really have to remind them that 90 to 95% of HIV care is outpatient, right?
Yeah.
We're down to seeing people maybe twice a year, right? 2 times Q6 month, or just send your labs. They're injectables, right? I joke with some of my medicine colleagues that I trained with, would you rather have HIV or diabetes? I'm like, ooh, pills every day. Oh, but now there's Ozempic and injections now, stuff like that. I know, but
like
blood
type
vessels,
1 or type 2.
Type 1 or type 2. Blind, dialysis, right? Your sexual organs not working well versus getting injected.
It's so funny that you asked that, because
joking,
a healthcare
right?
professional would actually be like a
layperson. They're like, diabetes. And I'm like, really?
I don't know.
Blind? You see that lady over there? That black toe? I don't know about that, right? So it's joking, but not really, right?
Yeah.
But I think making sure people understand what HIV looks like, what a career in ID looks like. It can be policy. It could be public health. You can run a Department of Health. You can be an advocate for international studies or USAID or, well, not USAID, unfortunately. Right? But the importance of vaccines. One of my friends, I was at a meeting recently, and I think the discourse over vaccines, yes or no, it's been different even since COVID, or childhood vaccines, or what does harm look like, or do we really need it? And I said, someone who's experienced it, it's not great to have measles or meningitis, or a kid who's deaf because of something that was preventable. But he had a hat on that says, there's still, some people still debate whether vaccines are the etiology of autism or make things worse.
Yeah.
I do not believe so, and the data that I'm exposed to would dispute that. But he had a hat on that said vaccines cause adults. And I said, I love that.
Yeah,
right?
I love that.
But it's kind of learning to think of not just the patient here. We talked a little bit about herd immunity, the importance of taking care of the whole community as much as possible, right? And kind of education and being prepared for outbreaks, biopreparedness, emergencies. There are things that, we couldn't fight or see that we can get a vaccine we saw for COVID in a year and a half, which is I didn't even believe
outstanding.
I didn't even believe it. People are like, can we get a vaccine in a year? I was like, absolutely not, but good luck.
Yeah.
But we did, right? We changed things.
I feel pretty lucky working in healthcare that there's not a stigma around HIV anymore. But I know that there still is a stigma.
There absolutely still is, unfortunately.
Why is there, and how do we get rid of it?
I think, again, education, and I think people, because it has to do with either sex or behaviors, people kind of have that thing that you could have prevented this, or it's because you're doing this, or you chose this, or you deserve this. And again, some leftover either kind of religious or familial, things like that. So one of the things we work about, again, is demystifying it, decoupling it from what you do or what sex organ goes in which orifice, to more about health.
Right.
Just like when I go to the doctor, unfortunately, they weigh me, right? And know my blood pressure. And that's really because at my age, at my sex, in my community, these are the things that put me at risk for not being well. All right? I'm also in that age bracket where HIV is still in kind of the players as the top 10 things that can make me sick or kill me. So I should know my HIV status. So everyone should. So I think doctors and healthcare professionals talking about HIV testing or knowing your status as just part of routine
just put it in
health.
The same conversation as blood pressure.
Right, exactly, right? A 30-year-old, are you really going to have a heart attack? Probably not right now, but it's good to know.
Right.
You're probably more likely to be at risk of having new sex partners, dating, unprotected sex. Know your HIV status and things like that.
Yeah.
So stigma, and again, marginalized communities or populations that have higher risk of acquiring HIV. Unfortunately, in this country, it tends to be not just men who have sex with men, but men who have sex with men of color, transgenders, but transgender of color especially.
Right.
And we're doing a better job with women of color in terms of new HIV infections, but still outpacing their white counterparts in terms of, black women only make up about 13% of the population, but almost about 50% of all the new women diagnosed, and similar for men who have sex with men, especially of color. So if everything was equal, we'd be 14% of the population, we'd be 14% of the new diagnoses.
So that's where some of the demystifying the stigma needs to focus.
Right.
What about cure? How far away are we from a cure?
Cure is different, right? So remember I spoke a little bit about we can cure hepatitis C. HIV and hepatitis B, we suppress right now, right? Because HIV is clever when it's making copies of itself, when it's making new babies or new viruses for the viral load. Part of that life cycle is the genetic information from the HIV virus sticks itself into your DNA, right? Something like that, right? To kind of take over the protein-making factory of your CD4 cells to make more copies, right? The way I explain it to residents or people in training, imagine if you think of your CD4 cells as your soldiers. If your soldiers see something that's going to kill them, right? If there's poison gas or bullets out there, they're going to go into a foxhole or go into hiding. Your CD4s do the same. They kind of go into a resting state, we call it, or the reservoir, cells that will hold on to that HIV information inside the cell, that HIV DNA stuff, right?
So a cure would have to be a genetic treatment.
A genetic treatment, or we'd have to kill all the hidden cells in a way, right? So interestingly enough, there have been a handful of people who we have cured of HIV, but it was a very sickening process. Just by coincidence, they had lymphoma, leukemia, those things that we get bone marrow transplants from, right? So for our listeners, for some of the cancers that are kind of affected by the cells, the cells that make your new red and white blood cells, right? If we can't do transplant, the chemo doesn't work, we will actually take someone else's DNA, right? We'll try to essentially kill all of your cells and give you new bone marrow that'll make new cells that aren't essentially your genes, right?
Yeah, that sounds
but are
like
making
something
new,
really
fresh like
aggressive to do for someone who's undetectable and doing fine.
But what if they have that, like HIV wasn't killing them, but he needed a bone marrow transplant to keep him alive because there's leukemia. So what's interesting.
So those people got cured by default.
But the other thing is, you need to have like a genetic match. You got to find a donor who's a match. There's actually a mutation that some humans have that makes it particularly hard for them to get HIV, even through sex and stuff like that.
So those are the people's blood we want.
These researchers who are doing the original one.
This is going to blow people's mind when they hear this.
No, but I mean, if you think about it, you're like, that's fantastic. I'm going to give you someone else's cell so that will help you make cells that don't have the leukemia in it. But I'm also going to try to find one, not just a match or those other matches that we got, that also have this genetic mutation that makes it hard to get HIV. Even though you're undetectable now, I'm going to try to kill all of those HIV hidden information cells in your lymph nodes and your
they're getting
reservoir.
radiated.
They're getting We're going to melt you.
Yep.
We're going to kill
and
all the
we're
stuff.
going to give you the good.
We're going to give you someone else's DNA, right? You're going to need some, but we're also going to give you cells from a person who genetically would already be hard to get HIV. We're going to give you HIV medicines for a few months, and we're going to check. Then we're going to stop everything and see if HIV crops back up. And to date, there have been a handful, less than 10.
Wow, that's
but
amazing.
Again, you can't give everyone with HIV a bone marrow transplant, irradiate, get stuff like that. But they're trying to use some of that science behind it, the gene editing, there's some techniques called the kick and kill. We're going to wake up all those resting, hiding soldiers, get them out in the bloodstream, kill them all, and then see if we can eliminate the reservoir.
Amazing.
Right? We're going to try to do gene therapies so that your new cells can detect. So we're not.
So how far, if you were to put a time frame on it, when do you think there'd be a cure? Even though technically you just said there is.
For some people, it's not for prime time or it's not for the masses. I'd say maybe 15, 20 years.
Okay.
I'm not sure. I'll try to hang on for a little bit longer.
Right.
But things are moving exponentially fast. Ever since the human genome was not even 20 years, right?
Yep.
The CSI, DNA, or all that other stuff, that's new stuff, right? Yeah. HIV to go from treatments to once a year, possible. Things are moving so incredibly fast. Yeah. Right. That
a lot of the things cured. I've had a lot of guests on this podcast, and we were talking about autism, and it's the same thing. It's targeting specific genes. Right. That's what it comes down to.
I mean, and I think now even with the advent of AI and computer modeling and large language modeling, and the fact that Sinai has an AI department in the last 12 or 18 months. And we're a huge system with a huge database, right? And people giving their blood, giving a little, saving the biorepositories. Right. I think all things are possible. The fact that, we can find mistakes and look around and pick all these things like that. I think it's closer than we think. But again, your kids were born at the right time. We were born at the right time, but we did good work, and our kids were born at the right time.
Thank you.
There you go.
Well, as we come to a close, if you had to give a public service announcement to say something on television to the community, what would that look like?
HIV is not the same as it was in the 80s and 90s, and the best things that you can do for yourself is to know your HIV status. Go get a test. If you are negative, we have ways to keep you negative. If you are living with HIV, we have ways to actually prevent you from transmitting it to anyone else, preserve as many years of healthy life as possible, and to live a full, complete life. The most important thing that you can do is know your status and protect your fellow man, your loved ones, and your own health.
I love that.
You deserve to live a healthy life, and you were born at the right time because we have access. We have both hindsight, but more importantly, foresight. Awesome. We're working on an injectable PrEP. Remember I said how exciting it was?
The bleb.
One for every Q6 months?
Yep.
There's a formulation of that medicine. It's called lenacapavir. We're opening a clinical trial. Actually, we just had our first patient enrolled 2 days ago for that same one that's every 6 months, a new formulation, an injectable, so in the muscle, but once a year.
Wow.
Imagine getting an injectable medicine for HIV prevention once a year. Yeah. I was like, I go to my dentist twice a year.
We've come a long way.
We have come a long way.
Thank you so much for being here today.
You're welcome. Thank you for the invite, and keep doing what you're doing.
Thanks.
All right.
That's all for this episode of The Vitals. I'm your host, Leslie Schlachter. Subscribe to The Vitals and the Mount Sinai Health System's other video podcast programming on YouTube, Apple Podcasts, Spotify, or wherever you get your podcasts. To learn more about Mount Sinai Health System's work in HIV/AIDS treatment and prevention, or to book an appointment with a Mount Sinai expert, scan the QR code below on your screen or click the link in the description below.